everybody. I think people are coming in. I see some familiar names here. Thanks everybody for joining us. We'll just give it a minute or so to let people join. Okay, so I think that's everybody for now. We may get started. I just wanted to introduce myself. I'm Karen Gibbons. I work in the School of Public Health and I sit on our newly renamed SPH EDI Action Group, I think is our name now. So just wanted to welcome everybody to our second SPH Community Influencer session. We had one last month for Black History Month. This month we're kind of celebrating Women's History Month. It was International Day of Women, I believe, on March 8th. Technically, apparently, Women's History Month in Canada is in October, but in the United States, it is in March. And you know what? We can celebrate women whenever we feel like it, I think. First, I just want to acknowledge that we are located on Treaty 6 territory and we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I invite you to acknowledge the Indigenous people, lands, and stories from where you may be currently residing, if not on Treaty 6 territory. I'm going to introduce our speakers, and today we have with us Zubia Mumtaz and Mary Modayil. So Dr. Mary Modayil is a scientist with Alberta Health Services, Provincial Primary Health Care, and works from the Edmonton General Continuing Care Centre in Edmonton. She received her Master's of Science in Population Health Sciences from the School of Public Health, so she is one of our alums. She received her PhD in epidemiology from the Arnold School of Public Health at the University of South Carolina. Mary's projects include developing a population health framework that can be applied across the continuum of care and examining the impact of upstream social determinants of health, such as social isolation and health inequities, on health outcomes. Her research focuses on systems and policy approaches to changing health behaviors and using both quantitative and qualitative research methodologies to inform decision-making. Previously, she worked at the University of California, Davis, and San Francisco campuses, and she has held contracts to work on chronic disease control projects at the California Department of Public Health. So she has got a long history in public health, that's for sure. She continues to serve on a colorectal cancer screening advisory group to understand reasons for poor screening among South Asians in California. Dr. Zubia Mumtaz is a professor of global health in the School of Public Health currently. Her research focuses on global maternal health, specifically on how gender and class inequities are reproduced in maternal health policy, program design, and delivery of services. She develops and tests interventions to ensure delivery of quality maternal health services for neglected and hard to reach women living in fragile, low conflict zones, such as Pakistan and Malawi. So Mary and Zubia will each chat with us about their public health journeys as women, their work and the impact they have made on other women and others in public health and public and population health. And then after, we will open up the session for a Q&A. So you'll be able to pose your questions in the Q&A box, which you should have on your bottom menu panel, I believe. So with that, I am going to turn it over to Zubia.
Hi, everybody, and good afternoon. So I was invited to talk about myself and the work that I have done so far as a woman. And it's always a challenge to talk about yourself. So Aaron, you're going to help me out here. But just to start off, I am an African woman of Pakistani origin who is now a Canadian. So that's a bit complicated. You can call me a global citizen or you can call me a global squatter. I think Norm Newman gave me that name. Anyways, I grew up in Kenya. I have lived in Pakistan, the UK, the USA, and in Canada. So the two of the longest places where I've lived in is Kenya and Canada. So after doing my high school in Kenya, I went to do medicine in Pakistan. And from there, I started practicing medicine. And it was while I was practicing medicine, I realized that I am seeing women at the end of their the the outcome of all the various proximal factors that led to this negative outcome. I was looking at a woman who comes to me for her sixth abortion, and she wants to, her husband beats her up, but he will not use contraception. And I said, so now really the problem here isn't giving the abortion. The problem here is much deeper. So I went ahead and I did a master's in public health from Harvard University, and then I did a PhD from the London School of Hygiene and Tropical Medicine. So when I was doing my PhD is when I first got involved in living when working with women in rural areas. So basically the focus of my research now, and that set me off on this trajectory, is to look at how inequities are structured in societies, both class and social class, gender and social exclusion, and how these structure both women's reproductive health as well as the policies and the design and the delivery of the services. So so basically, the two unique characteristics of my research are that one, I give voice to the voiceless women. Just to contextualize it, 1,600 women die every day in childbirth. That is the equivalent of about 4 jumbo jets crashing. Can you imagine if 4 jumbo jets crashed every day and they were full of men, North American, white, etc.? We wouldn't be sitting so quietly. But because these are women and they are poor women in some of the poorest countries of the world, their deaths go unacknowledged. And the second thing I do, and so to do that, I work and I live in villages and in some of the remotest, some really remote areas. It was during my PhD that I first got introduced to a life in a village, and I got hooked to that life. So for the past nearly 20 years now, not 20, I guess 18 years, I have been working constantly in these, living and working in rural areas and accessing and understanding how these women's lives are structured, both class as well as gender, and and how it impacts the services and how services are delivered to these women. So sometimes these places can be quite dangerous. One is, of course, they're very uncomfortable. So I live in the temperature is 45 degrees and I have 3 liters of water to use. And that means everything, drinking, bathing, everything. So that kind of, experiencing the women's lives as they live them kind of enables me to understand what they go through. But secondly is that more importantly, I have been working in places like Pakistan, which for the past two decades has been I guess, the ground zero of the war on terror. And so I end up working in rural areas, which sometimes puts me in places where I have found myself in Taliban territory. Um, I'm there to understand, the reproductive health issues of the woman, and the grandma starts talking to me, moaning, crying that my son has been taken away by the local Taliban leader. And I'm a bit worried, what am I doing here? And she shows me the picture of the son with, and I'm looking at him and I'm saying, this guy isn't an innocent guy. This guy looks like a professional Taliban fighter. And so I'm in the house of such people. Uh, and when I was sharing this story with a colleague of mine, he looks at me and he says, "Are you crazy? What were you doing there?" I had a cousin. This guy shared with me a story in which his cousin was kidnapped from the same space that I was in at the time that I was in there. And he says that he was only found by chance when the army raided some hideout. So, and the other day I was publishing some of this research, and my researchers and the reviewer tells me that you why didn't you do this and why didn't you do that? And I said, okay, fine, now it's time to tell you the context in which I was collecting this data. And that the security people were unhappy, but not unhappy, they were scared of my presence in the field. And they would in fact, the people had been kidnapped and some people had been killed. So that kind of tells you the context in which I was trying to collect this data. But uh, these are the very women who need to be talked to and whose voices need to be heard, because they are silenced completely by the way the society is structured, the way we are all structured. And so the second thing that I do is I work closely with the governments of Pakistan, Malawi, and as well as internationally with the WHO and other UN agencies. So it enables me to take the experiences of these women living in very remote areas and to bring it on the policy tables so that their needs are at least not front and center, but at least they're visible. So I guess that summarizes some of the things that I do. I'm open to questions, and over to you, Mary.
Thanks, Zubia. That is a really powerful comment and conversation. Like, I have not worked in conflict zones, and I would say I have worked in mostly safe environments. So let me provide a bit of my background. My perspective will probably be quite different, even though we do share some backgrounds that might be similar. I was born in India. I've lived in Canada and in the US in terms of the bulk of the years that I've spent studying and working. And as was mentioned earlier, like, did my master's degree and my undergraduate degree at the University of Alberta. I want to say, like, in terms of like women's role in health and public health, I think I did not appreciate how many women choose careers in health, in public health specifically, until I actually enrolled in my master's of public health degree. And I don't know how many of those who are in this room today had the same experience as me, but the bulk of my classes in my undergraduate degree were comprised of not women, but mostly men. And then when I switched over to this master's degree program, I suddenly found myself in a crowd of women, which is really interesting. So it was a bit of a shock to my system to see like so many women like taking up this career. And then in terms of my work, I'm also seeing the same thing. I will say that I chose to focus on chronic conditions because I see chronic conditions as the more wicked problem. And what I decided to do in terms of looking at inequities is I focused on areas that seem to be like less accessible or less serviced. And the reason for that being that I think a lot of times those of us who might either be working or or studying in more privileged areas, we don't actually recognize how easy it is for us, right, to access services. And so when I was looking at my master's degree and then my PhD, I also focused mostly on inequities, focusing on breast cancer first. And then for my practicum, I focused on cervical cancer. And I don't know how many of you know the demographics in the South, in the US, but mostly the population is it's very different from what you'd see, I think, in Northern US and even the Western US. It's mostly comprised of African Americans, and the disparities in cancer affect, not surprisingly, affect African Americans more deeply than they affect non-African American populations. And so I focus mostly on that population in terms of collecting information and collecting data, and also attempting to look at interventions that might actually be feasible in their daily life. So a lot of times when we design public health interventions, I don't think we necessarily look at scaling or spreading, but we just look at efficacy, right? Like how well does it work in a trial? So what I was trying to do is more of that phase 2 or phase 3 trial in terms of trying to understand feasibility in African American populations. For my cervical cancer work that I did, I found that to be really impactful because it was looking at perspectives from providers and looking at perspectives of women and looking to see, is there actually a disconnect between how providers see why women don't show up for follow-up care when they have an initial pap smear versus how women see that. And so I think it was the first time I'd actually really understood like that perspective, like the need to actually speak to patients, to speak to individuals who are receiving services rather than those who are just providing services, right? So, and there is actually a very different perspective that I saw. The other challenge that I noticed was, I mean, this might be true, I think, across a lot of our work is, we do a lot of work in academic or very highly controlled settings, and how do we actually ensure that those learnings are actually implemented or taken up in real life? And my work in epidemiology, I mean, it was great in terms of rigor, right? And I was able to show the effect, but I wasn't able to necessarily say, this is what can happen to that research, right? In terms of uptake. So I didn't have any background in policy, and I wanted to see if I could somehow work in a policy role, which is why I chose to take this role with the University of California, and then working with the California Department of Public Health specifically to see how can we look at interventions that are ready for scale and spread at that state level, and ensure that people are actually able to be impacted or be influenced to do that, right? So it doesn't sit just in that academic kind of setting. So that's what I was trying to do. And then finally, I came back here about 5 years ago, worked for Alberta Health Services, and I have to be honest, I had no intention initially working with healthcare services because I didn't see really how healthcare services was really playing a role in affecting those determinants of health. But I think I've been lucky. I landed in primary healthcare, and primary healthcare's role being that first point of contact, they've been really helpful and supportive in terms of at least having that conversation. And so we are trying our best at that provincial level to influence how people consider the determinants of health, and specifically looking at income and looking at how income affects health in Alberta Health Services. So yeah, so that's been my role in my work. And I have to say, I think the role that I see in terms of women's role and women's perspectives is, I think, really important, because not just because we happen to be the majority of the workforce in healthcare that I work with, but also I think women tend to be less visible at the decision-making tables. So it's really important that we speak up.
Thank you both for that. I'll maybe just say first, Zubia, I'm glad that you were never kidnapped. It's certainly a different world than what we have over here, and so it's amazing that you put yourself in those situations for the health of women, for sure. I'll maybe start off with a question, and it's probably, COVID is, of course, on everybody's mind, and it's, I think, the first thing that everybody talks about. But, so for Zubia, you look at reproductive health, and Mary, you look at chronic conditions, and, both of these things are not going away. Even in a pandemic, we still have people getting pregnant, and people are still dealing with their chronic conditions or being diagnosed with chronic conditions. So I'm hoping that both of you can maybe talk about how the pandemic has impacted the communities that you work with. Yeah.
Okay, so should I start? Yeah. So my experience of the pandemic has been very, I guess, two ways. On one level, what has happened is that COVID has, I guess, I'm not sure if COVID hasn't hit Pakistan and Malawi in the same way that it has hit North America. There is a question of the severity, the question of the prevalence and incidence of the infection, I guess, because of not sure there's much research around it, but it appears that there might be a certain element of cross protection given from people with flu infections. So in the Western world, because we have been receiving flu vaccines quite commonly over a period of time, while the concept doesn't exist in Pakistan. So it appears that people are getting the infection, but they're not maybe that serious. That said, that seems to be not much research has been done, but I did come across an article that they're starting to talk about the possibility that if you have flu infection, the COVID isn't so serious. But anyways, what I'm trying to say is that it's, so because of that, the people are living pretty normal lives. And so life is going pretty normal. My research studies stopped for about 6 months, and then we restarted again last September. And in rural areas in particular, COVID isn't such a serious matter. It's to a certain extent an urban problem. That said, it's interesting that when last March, when the pandemic started and nobody knew what they were dealing with, so all countries were kind of gearing up, to how the hospitals were gearing up to deal with the deluge of patients. And what the hospital in Peshawar, for example, did was, of all its various units, it shut down the obstetrics unit. Just simply shut it down so that we can divert our resources to the expected COVID patients. You're just left wondering what happened here. That you think women aren't going to be having babies anymore? Or do you think suddenly women in March and April will not be having complications anymore? But suddenly that they were let, and that seemed to be those people, for them, the most sensible decision to make. So it just kind of, this feeds into this whole idea how the gender values that devalue women are always at the surface or just beneath the surface. And the minute something goes wrong, the first people who can be forgotten about are the women. And Mary, you commented that when you first went to public health school, you saw so many women. But I just want to say that despite the prevalence of women in public health, the leadership is still in men's health and public health. So that disconnect remains. It's still a challenge at every level.
Yeah, I agree, Zubia. I think I do see the same disparity at leadership tables here at AHS. It is mostly comprised of less diverse than I would have expected, not representing our communities in Alberta, and mostly not women. So it is unfortunate. I have to agree. My parents have been spending the last year and a half now in India. South India is their retirement spot, but they usually live in Canada during the summer, and it's been really difficult. It's been difficult for my nieces and my parents not to be able to see each other because my parents were unable to like travel over and spend time here last year. And right now it's been really easy for them in terms of getting anything done because they're able to see like all of their family, their community, and really live a regular life. Like COVID was tamped down very quickly in India, in Kerala, in South India, compared to Canada and most of our developing world. So they've been fortunate, like they've received their vaccines and they're living life as they would. So it's just a matter of now trying to understand how do we do the international flights and the connections now, once it feels safer to travel. I will say, like, most of the work that we're doing for COVID has been focused on primary healthcare because that is the team that I work with most closely. And I don't know how many of you have heard from the news, but we've shifted a lot of our work now. So one of the challenges, which has been highlighted in Alberta, has been trying to get people to come in to see physicians. And a lot of that, I'm sure you've heard, has shifted over to virtual visits to address that concern so people don't have to show up in person. So AHS is committed right now to building evaluation framework to measure the success of that, to see whether or not virtual visits are actually able to provide care in a similar manner for many conditions. So that's the bulk of our work right now that we're focused on. The other piece is what we're working on as an organization is trying to understand what is the impact of COVID on patients in the population who were not able to access care or who are currently not able to access care or not wanting to access care because they feel, deem it unsafe. So in primary healthcare, we've had about 200,000 individuals who were not seeing their physicians last year, and it was specifically between March and June of last year where we saw that drop off, and we haven't seen the uptick yet this year. So compared to the previous, 2019, we did definitely see a drop in patient visits last year. Well, it's actually Albertans, number of Albertans who have visited, so 200,000 fewer Albertans have visited physicians last year. The other thing that we're trying to understand is in terms of the future, so next year, 2022, what is that specific impact on the healthcare utilization of patients? So because people didn't show up, are they going to be showing up with more severe conditions? For example, cancer. Have they delayed surgeries that need to happen? I mean, I think some of the disease outcomes or the healthcare utilization outcomes are pretty simple for us to model because we've actually been able to track those. Some of them are not going to be seen, for example, mental health. For example, we do know that mental health is not just access through Alberta Health Services, right? There's a lot of private, and also because funds have been provided through the federal government, people are able to pay out of pocket for services that they normally would have just access through more free services. So some of that we won't be able to tell, but we are actually, there's a pretty large commitment right now to understand that. And I know Verna, who's our president, is really interested in understanding that and sharing those learnings in a few months with the ministries.
Great, thank you both. I think we have a couple of questions in the Q&A. So I'm going to start with the first one. You both have amazing careers. How can we support young women to pursue similar education and careers, especially in a time when more women are leaving the workforce due to the pandemic? It's a great question.
Can I take a shot at it? I mean, as a person who actually experienced a lot of the issues that are going on nowadays, the things that are happening in during the pandemic was actually my life as a woman, as a mother, as a young mother without much support, etc. So I think one is that I think this pandemic is hopefully a temporary push out. So women are now currently and in a situation where they have to look after their families. And I always tell everybody that that is the most important thing. Your family comes number one, and you have to give the children the time that they need. This time will never come back again. You know, I always tell my students that if you have a young child, you know, if necessary, if you even have to postpone the first 1,000 days of the child, the first 3 years are never going to come back again. You're going to have 40 years of a career, but those 3 years, you know, are never, the child is never going to be a baby or 2 years old again. So first focus on your family, number one. Number two is that when the pandemics, you know, comes to an end, I think we, at the policy level and at the senior management level, will have to step up. And you'll have to step up and stop comparing women's career progress with men. We seem to have set up standards of career progress which are male determined standards. They're not women determined standards. So a young man graduates out of university, he doesn't have to worry about anything. Just look for a job, work on it full time. You don't have any household responsibilities. You never become pregnant. You never go through childbirth. You don't take a 1 year mat leave. And even after 1 year mat leave, what makes you think a 1-year-old child is perfectly ready to look after themselves and you're ready to go back to work full time? So this is where policy needs to step up and say that we're going to evaluate women's career progress differently from men's. And that is, so if you have a woman, say for example, I don't know who this attendee is, but if you are a hiring committee, look, a man's 20 publications are equivalent to a woman's 5 publications as far as I'm concerned, because she has given so much of her time looking after the babies and the children. And, you know, there's certain things only women can do. Only a woman can mother. Let's not forget the role of mothering. And so we need to take into the account. So I think the number one thing is that you need to develop separate criteria, not compare them to men. Men's criteria should be completely different from women. And number two is that if women are showing a career break 2, 3, 4, 5 years, just ignore it. Don't ask questions. What were you doing in your career break, etc., etc. We should understand what happened, and let every woman's life is different. So we need to kind of, I know some steps have been taken, but I still don't think they're sufficient. Canada is miles, years ahead of the US in terms of its maternity leave benefits. It's 1 year compared to 3 months, not compared to nothing, I think. Or maybe some companies give you 6 weeks, but we're still behind the Nordic countries, which give you 3 years off, right? So now slowly they're starting to come up with giving a 1 year extra. You know, they understand that a woman took maternity leave for 1 year. But you know, of those of us who have babies, nothing changes after 1 year. You still have a baby who's 1 year old. So I think we need to be much more gentle with the women if we want the women to come back again and not be set back by the 10, 15, 20 years that they might get set back with this COVID pandemic.
Mary, I'll maybe add on to the initial question and then and direct this piece to you. Fulakemi, she's one of our students. She asked, what advice would you give young female public health professionals who are just starting out in the field?
Yeah, Fola is one of my students. I'm taking her on this year. Hi, thanks Fola for the question. You know, I think I may not have spoken to Fola specifically on this question, but what I do advise is really don't worry so much about the actual job that you're doing. What you should be doing as a student, or even just trying to enter the workplace, is really trying to understand, like, where do you want to impact the world or the field, right? And then gather experiences through your work. So it's not necessarily like making a commitment for 5 years or 10 years to a job or to a position. It's really gathering those experiences and then like trying to figure out like, what is the role that you can play or what is your responsibility that you can be taking on to further the field. It's interesting because I think of this like almost as a generational thing. Like my parents had careers that lasted, a good 40, 45 years, right? And I mean, even though I've gone into the more of that research area rather than into, I would say, professionally saying, oh, I'm going to be an academic, or I'm going to do healthcare, or I'm going to do public policy at the state. What I decided to do instead was say, these are the areas that I want to work on and advance. And so for me, it was really trying to address equity in health, and specifically like now it's addressing equity in healthcare. So for me, it was that perspective. Some people I know who I work with are very passionate about evaluation. So it's not really it's not really like I would say like the specific topic of interest. It's more that they're just interested in anything to do with evaluation and are willing to take on any evaluation roles, right? So that's what my advice would be, to really like follow what it is like that you want to be advancing in your field or in your career, rather than a specific job, because I think in the first 5-6 years, people could be taking on like, 6 different kinds of projects, and still being able to advance those really well as a field.
All right, thank you for that, Mary. We do have another question from one of the attendees, and they're wondering if you can share what the most prevalent issues are that you are currently working to address. And I'll maybe add on a second piece to that question. What can the School of Public Health do to help address those issues that are so prevalent?
Zubia, did you want to go, or did you want me to go?
Mary, why don't you go ahead?
Sure. Yeah. So I there's a gap in terms of, I always see that there's a gap in who we hire versus what people are trained for. So in our field, like in healthcare specifically, I think public health comes in with this strength. The strength being taking this, usually a broader perspective of health, really focusing, I would say, on primary prevention. In healthcare, we take more of that secondary and tertiary prevention, right? So when we speak with healthcare professionals and then people who work within our portfolio, I mean, they're passionate about addressing the social determinants of health, but they don't really understand what their own roles are. So how do we take on those responsibilities within our roles? And that is, I think, the gap in terms of what we are trained for versus how we practice.
Okay, so I guess I can answer the question about what am I currently working on. So my current projects are, the biggest one is looking at the issue, studying scale up. So one of the, I can see Mary's scale up. So one of the big problems we have in public health, or actually specifically in global health, has been the world of projects, and projectitis is how I call it. So a lot of global aid goes to developing countries in 3 or 5 year projects. And the whole idea is that they will be scaled up. So millions, if not billions of dollars have been spent on projects, which then die out at the end of the funding cycle. So, and when the occasional time when some is scaled up, they really do not deliver the kind of results that the projects do, because a project is what my colleague Steve Hodgins calls is a program on steroids, and then the reality hits. So my current program is looking at a scale up of a program that aims to convert all first level care facilities in rural Pakistan to provide round the clock care. So we are looking at all the challenges, the programmatic challenges, the quality of care that has been provided, and how this program is weaving into the existing healthcare system. So that is my basically quality of care. This has been what I've been working on, and quality of maternity services. I also want to answer a question that one of my students asked about what advice would you give to a person new to career? And, and Mary is the best person to answer that because she's in the so practice field. But I would like to say for Lakeme, follow your heart, follow your passion. And I know sometimes it's a challenge between what your passion wants and the reality of looking for a job and getting a job and, paying the bills. But try to find a sweet spot where your passion aligns with your jobs. And if that means changing 5 jobs in the first 5 years, be it. But always follow your passion because that will lead to you can wake up in the morning every morning and jump out of bed.
I agree, Zubia. Actually, I have a comment to make as well, because I was just reflecting on what you mentioned earlier. I agree. We are a land of pilot projects in Canada. We have thousands of projects that we fund, and then they just die out and they never go anywhere, right? So, I mean, that's a major issue for us. And the other thing I was thinking of is we're not really, and I think I've talked to both Fola and Sharon, like the students on this earlier, but we're not really embracing innovation in terms of the concept of allowing ourselves to fail, learning those lessons from failure, and then being able to pick it up and say, okay, what did we learn from that we can apply, right? So when we fail, we just walk away from it like it never happened. So I think there's a lesson in that failure that we need to be taking up.
So it's kind of interesting, Mary, to see that I work in global health and you work in the Canadian context, and yet the issues are so similar. Mm-hmm. I thought it was the donors funding structures that led to these projects. And yet you're saying that the same thing is happening here. And so I think you're right. We're not failing. We're not willing to learn from failure. I teach program evaluation. And so what I've noticed is that a lot of donors in particular, and I guess that donors exists everywhere in the world, right? Could be Canadian government or could be Canadian government that gives aid. There's very little stomach to learn from failure. It's better to, shut it, wrap it up, and go on forward. And by failing to learn from failure, we keep on repeating the same things.
I love
one of our biggest problems. I'm sorry.
No, go ahead, Mary.
I was going to say it's one of our biggest problems that we are putting, really focusing on in AHS. Like we created these strategic clinical networks within AHS. This is unique for healthcare systems in Canada. So it's a great opportunity for research to interface with healthcare service delivery, right? To understand how do we do it better. So over the last, I want to say 5 years that I've been here, we've been really introspective in terms of like, where are we failing? Where are we funding? How do we do this work better across the organization in terms of thinking through innovations that we're willing to fund? And how do we support that idea of like learning from failure, right? So it's just starting to catch, that conversation is just starting to happen here.
Okay, no, that's excellent. That's very heartening to learn that there's that thing. And I also liked your comment about innovation. I think I have some strong opinions about the use of the term innovation. I think we use it a bit too loosely. There is a tendency for two things to be happening simultaneously, and I'm sure the audience has a lot to add to that. And that is, and I know we're supposed to be working about women, but some of these issues apply to all women and men, right? So, what happens is that on the one hand, and again, global health context. So, no, please don't generalize it. So in the global health context, it seems to me that on the one hand, we are constantly talking about really big ideas, that we want to be innovative, but failing to realize that does this innovation have fit into what is going on in those countries? And I'll give an example of it. So there was a project when I was in Malawi. So there was a project on a continuous professional development. And because it is such a challenge to provide this kind of continuous professional development, somebody came in Canada came up with the idea of providing them with online training. And so the whole thing was developed and computers were sent, and so there's a bunch of computers that were purchased and installed in this lab in the hospital. And the whole idea was that the staff would go and learn on those computers. And I went there 3 years later, 3 years into a 5-year project. And those computers had yet to be switched on. And I'm serious, yet to be switched on. And there were two reasons for the yet to be switched on. One, the key one was there is no electricity on those facilities. In rural Malawi, you don't have electricity. So the electricity used to come for maybe 1 or 2 hours every 24 hours. And the rest of the time, if it was nighttime, they'd use a generator. So those computers were never going to have electricity to be switched on. And the second minor point was it was 3 years later and nobody had borders to switch on the connectors for the different kind of 110 and 220 volts. And I'm looking at these computers and I'm saying, oh my God, that's a lot of money down the drain. And the third thing was, there's a huge staff shortage. So whenever those people were at work, they were busy delivering babies and nobody was going to see those computers. So, these are the kind of information that needs to be incorporated when you are developing in innovation. So innovation has to be viewed very broadly, not just technology.
Totally agree. Totally agree. And when we apply design thinking, or that idea of like creating products or services, and it has to hit, like, where does the rubber hit the road, right? Like in terms of implementation of that. So there needs to be a model for that. Electricity is important, obviously.
And just to add to that, I see there's a call for artificial intelligence projects in sub-Saharan Africa. And I'm looking at them and I'm saying, wow, do we even know what artificial intelligence is here? That we are looking at developing it in sub-Saharan Africa just because it is the latest buzzword?
I wish we had another hour to continue all these interesting discussions. And I love the connections that the two of you are making, even though, as you said, Zubia, the context that you work in are very different, but there's still a lot of similarities. So we'll maybe go with the last 3 questions because we are coming to our end. But so Denise Spitzer, one of our faculty members, has a question for Mary. So you mentioned, people have been avoiding care. Could you comment on Alberta Health Services' commitment to ensuring healthcare for undocumented or uninsured workers?
This is a really good question. It goes into data and how we collect data. One of the things I want to mention, and I hope people keep, as this audience should keep like raising this point, we don't collect any socio-demographic information. We don't collect citizenship. We don't collect, for example, if you're First Nations, Métis, Indigenous, we don't collect that information. We collect no information that will actually help us address those determinants of health. So I don't even know where we'd even start being able to understand as a system how many individuals are accessing the system who are undocumented. I think we know of projects, like places that people are, where frontline physicians and care providers are encountering this issue. For example, the ARCH program at Royal Alec, right, where they're trying to address at least the ID program, that ID issue for patients. But again, we as a system are not actually documenting that information. So it's really scary. Where do we start with data even, right? Oh, and I guess the other piece that I've spoken about this or referenced this, I guess, in the past in other conversations, is that we do have a new electronic medical record system that's being rolled out provincially. It's called Connect Care. It's based on a US model. It's called Epic in the US, and we kind of consider that like the Apple product versus the Mac products that are used in other healthcare systems. So it's really friendly and easy to use, and there's a module within that is specifically supposed to be addressing or collecting information to address the social determinants of health. And like this is where I think that implementation piece is so important. Like just collecting that information, we have to understand like what are the best questions to ask in a Canadian context? And then are we as care providers are asking patients these questions, are we willing to ask those questions and then address those concerns? So yeah, big conversation pieces right now in IHS.
Thank you for that, Mary. I think we'll actually just go with one more question, and then what we're going to do, we do have 3 other questions, and we will send those to our panelists, Zubia and Mary, and get their feedback on those questions, and then we will send them out after this session. So I'll end with a really interesting question, a really cool question. So what is your favorite part of being a woman working in public health?
So I was looking at that question. I think that's a very interesting question. So for me, what I feel has been the best part of being a woman working in public health it has given me access to spaces in women's lives that I think no man ever does. And I can enter homes, I can knock on a house and go and enter a space in parts of the world where the women are completely secluded. And by doing that, I have been able to give these women a voice that has in ways that it wasn't possible otherwise. That said, I think the second challenge, but I think that's the best part of working in women in public health. I think we have managed to really raise the profile of women's health. You know, having a maternal health program, having a Millennium Development Goal, and then making sure for the last 15 years that we worked on it. And now also, although it has been subsumed under health, we're still focusing on it. So I think it's the women who in public health who keep this matter alive, because the natural tendency is to work towards areas which are, you know, I guess male dominant, you know, diabetes or cardiovascular diseases, and I don't want to devalue chronic diseases. Even within chronic diseases, you have to keep on highlighting what about women? What about women? And that is one of the things. I think we play a very important role. And as a woman, you keep on bringing the attention towards a population that tends to get invisibilized very quickly.
Yeah, I agree. For me, it's been really being able, and you know, sometimes I think it's the skin that I'm in, as well as the fact that I'm in a female body, right? Sometimes I think I don't have the same, like filter when people are asking questions or saying things, and I'm willing to actually speak up on topics. Because I know it's going to, no matter what I say, I know it's going to end the conversation anyway. So I don't really have that filter. So what I've really enjoyed is really like putting in a separate perspective from what the others in the room might be speaking to. And oftentimes it is, you know, male dominated conversations, right? And also the experience of care. The experience of care is very different for men than it is for women. In terms of care providers, I always say this, like a lot of the care providers, the nursing professions might be more, or historically might be more male dominated, or sorry, female dominated, but we are starting to see a little bit of a shift, right? Like we're seeing more male men in that profession. And then the other piece is who people feel comfortable receiving care from. So that's the other like major piece of this. Like if we always have that one perspective, which is, you know, whether it's like, you know, like if you're minorities or if you're a woman at the table, then that's going to drive actually the decisions we make in terms of care provision within services. So yeah, so that's why I enjoy actually adding my perspective, and not really like fearing like my, you know, the filter piece of it either, right? So gotta speak up.
Well, thank you both, Mary and Zubia. Like I said, I wish we had lots more time to discuss. I think you just both have such valuable insights, particularly for our female students in the school and females working in public health, for everybody, of course. As I mentioned, we do have 3 other questions that we'll send to the panelists, and we'll get their feedback on those. I think you should probably see in the chat box a link to an exit pass that if you, as an attendee, if you could fill that out, that helps us with our future sessions. And I think we should be good. I just want to thank you once again, Mary and Zubia, for coming to this session, our second SPH Community Influencer session. I think it was a really great conversation.
Yeah. Thank you, Karen. And thank you, everybody, for I guess what I felt was a rant, but never mind.
No, thanks, Zubia. Thanks, everyone. I appreciated this too.
Maybe we must stay in contact. I can share with you quite a bit of literature that I've written around learning from failure.
Totally. Yeah, we should totally stay connected. I think it would be important for our workforce as well. So thank you.
Thanks.
Yeah. All right. Talk to you later, everyone.